Here is an hypothetical scenario. Your neighbor has never been diagnosed with diabetes mellitus before, but just last year he was diagnosed with liver problem, and now he's battling with diabetes mellitus. Then you ask the question, is that possible? Can liver trouble, liver disease, liver problem lead to diabetes mellitus? You want me to answer you? Of course you do, right? Okay, let's go. You are welcome to my channel. Thanks for visiting. Remembering to subscribe, sharing my presentations, and listening to this very one. Today, we'll be addressing a big topic, but we're all familiar with it. That is diabetes mellitus. Diabetes mellitus should not kill you, should not kill anyone if you are ready to fight it. And you can ask me, how do you mean? Let's go. Before delving deeply into diabetes mellitus, we should know that we don't have only diabetes mellitus under the diabetes definition. It's possible that the individual could be dealing with diabetes insipidus. So there are two broad types, diabetes mellitus, diabetes insipidus. So the question is this patient having diabetes mellitus? Is it diabetes insipidus? We will know neither. One thing is common to both of them. That is, they both produce large urine. In diabetes insipidus, large amount of diluted urine will be produced. It may be central diabetes insipidus. In that case, there will be lack of antidiuretic hormone called vasopressin. This is as a result of trouble or dysfunction happening at the hypothalamic or with the pituitary gland. These will occur in the brain, right? And we can trace the cause of this sometimes to central nervous system infection or trauma to the central nervous system. If it is not central diabetes insipidus, it might be nephrogenic diabetes insipidus. In that case, the trouble will occur downstairs at the washroom or toilet, depending on where you are, or depending on the name you call it, toilet or washroom. And I call it downstairs because it's not happening in the brain. I call the brain upstairs, right? So downstairs, the trouble is happening right inside the kidneys in nephrogenic diabetes insipidus. Here, there is no adequate response to the instructions from the upstairs, meaning there's lack of sufficient response to the already produced antidiuretic hormone. That is the problem. Unlike the central, where there is inadequate production of antidiuretic hormone, in nephrogenic, there is enough antidiuretic hormone, but there is lack of sufficient response. We can find that in lithium trouble. When lithium causes diabetes insipidus, it will be nephrogenic diabetes insipidus. So sometimes I test by malfunctioning hypothalamus. That may lead to high water intake, and of course that will later lead to excretion or increased urine production, as the case is in dyspogenic diabetes insipidus. Dyspogenic diabetes insipidus is pointing to the fact that there is damage to the test mechanism in the hypothalamus. It might be gestational diabetes insipidus that could be treated with desmopressin. Insipidus simply means this is tasteless, while mellitus means it is sweet, both from Latin word. In fact, in the olden days, the way they test for diabetes mellitus or insipidus is that they will notice when the affected person has urinated, ants will come around the place where the individual with diabetes mellitus has dumped urine, and that would not be the case in diabetes insipidus. So the presence or congregation of ants around urine on the ground will give the clue that that is containing sugar. Okay, now diabetes mellitus. We've gone briefly through diabetes insipidus, right? So to those who in the past known that there's diabetes, now you know that it could be diabetes insipidus, not dealing with high sugar in your blood, not dealing with high sugar in your urine, but it could be diabetes mellitus, the one you are familiar with, that is the one with high sugar. Now, let's get down to diabetes mellitus. This is a metabolic disorder where glucose intake by cells for fuel is impaired. So there is excess glucose in the blood, excess in the urine, with the associated complications. Now, diabetes mellitus, fully. You've heard about type 1 diabetes mellitus, right? Okay, let's briefly review that here. Number of people with type 1 diabetes mellitus with acanthosis nigricans will be minimal. Okay, acanthosis nigricans. So it will be a form of rash at the back of the neck and some parts of the body. Let's just go on. Later on, we'll talk more about that. The onset of type 1 diabetes mellitus could be acute, and the first sign that the individual is having type 1 might be he or she is down with diabetic ketoacidosis. Admitted in the hospital, emergency room, while doing investigations, then they'll be, oh, this is DKA. Oh, high glucose level. Oh, high ketones. Oh, this is type 1. That might be the first presentation ever. Here, positive family history is not such a strong factor, but still possible. So about 10% could be linked to family history. Yeah. Here, autoimmune conditions will be highly recognized, or it might be majorly due to autoimmune conditions, HLA, DR3, DR4. It can be idiopathic sometimes in medicine. When we have tried to get a cause of a particular disease condition and we're unable to do that, we conclude and hide under the definition idiopathic or known cause. This is common when we're considering all races in the world. It's common in whites than the rest. I will tell you where whites will have less problem in a bit. But when it comes to type 1, and you want to compare Asians, blacks, Hispanics, whites, you'll find type 1 more in whites than the rest. But we should tell ourselves the truth, it is worldwide. So it is found in blacks, found in Asians, found in whites, found in Hispanics, Latinos, found everywhere, but more in whites. That is type 1. Here, the pancreas is in trouble. We'll be dealing with a situation where pancreatic function is insufficient. And with pancreatic antibodies, in about 80% of cases, the pancreas would have been destroyed before we will be seeing the signs and symptoms of diabetes in this patient. Let me repeat. Here, the problem is majorly within the pancreas. the pancreas is failing. Isolated cells of Langerhans are not working well. Okay, we can pick antibodies, pancreatic antibodies in these patients. But before the young lady or the young man with type 1 diabetes mellitus will be showing signs and symptoms of diabetes or DKA, 80% destruction would have occurred in that pancreas. So you can see why we opt for nothing but insulin that the pancreas can no longer produce. Because before we'll be able to pick that, the pancreas must have been destroyed a lot, 80% destruction. Here, when we assay the insulin and C-peptides, there'll be low insulin, there'll be low C-peptides. Okay, I will quickly go into that. Well, let me give you the reason why there's trouble with insulin and C-peptides. C-peptide is a part of proinsulin that is broken before it is also secreted along with the same insulin, okay? And we are not going to get this from exogenous insulin. So if someone introduces insulin from outside, we will not get this picture, okay? It is only when we are dealing with the insulin produced inside the pancreas, okay? Beta cell will be stimulated by carbohydrate ingestion or certain drugs like secretagogues like sulfonylureas will stimulate the beta cells to produce insulin, okay? And then insulin and C-peptide will be in ratio 1 to 1 molar, okay? Then insulin is largely cleared by the liver, but C-peptide is mainly cleared by the kidney. So insulin to C-peptide, when we take the blood peripherally, is less than 1.0. Why that? C-peptide is not affected by the liver. So liver is not clearing it. If insulin is introduced from outside exogenously, there will be hypoglycemia, correct? There will be increased insulin, correct? But the value of C-peptide will drop. Okay, pancreatic induced insulinoma is the one that will lead to both increased C-peptides and increased insulin. I think we got it right now. So the main treatment here would then be insulin in type 1. And then the age where we're going to find type 1 will mostly be childhood. But we can find it in adult if the result is because it is caused by autoimmune. So the autoimmune may develop later and destroy the pancreas, and then we'll find low insulin, low C-peptides, and the treatment will be insulin alone, exogenously. Then the diagnosis will still be type 1, though the individual is not a child, might be an adult. Autoimmune can cause type 1 diabetes in adults. Now, type 2. Oh, so somebody is saying I'm familiar with this. Let's go through this together. Type 2, remember I said ketosis nigricans will be minimal in type 1. Here, it will be significant. It will be present in almost 85% of type 2 diabetes mellitus patients and ketosis nigricans. The onset here is slowly. Remember I said in type 1, the onset is acute. And the first presentation might even be diabetic ketoacidosis. We'll later on go into hyperosmolar, hyperglycemic state, and so on, or non-ketotic coma, and so on. That may be the first sign too, particularly in individuals that will not be going to their physicians on time and will not be telling anybody that I'm peeing more, I'm feeling thirsty more, I'm losing weight, and so we'll go into details of all those later on. About 10% of patients with type 2 diabetes will actually have ketones. Well, this is to my friends in medical school. Some will believe that type 1 is associated with ketones. Type 2, no ketones. That's wrong. It's only that the percentage will be low. About 10% can still have ketones in type 2 diabetes mellitus. The family history is pretty strong here. Remember I said under type 1 that family history is about, in about 10%. Here is in about 80%. 80%. So family history is very important here. And type 2 will occur in all races. Okay, remember I said the other time that type 1 will be in all races, but common in whites more than the rest. Here, it is common in all other races than whites. So type 2 is commoner among blacks, Hispanics, and natives, Native Americans, Native Canadians is commoner. But we should tell ourselves the truth. This is a worldwide problem. Here, the other time in type 1, I said we'll have to give insulin, right? Here, this is suffering in the midst of plenty. Insulin is already here. The problem is there's resistance to insulin. Okay? Insulin resistance is the problem in type 2, not the lack of insulin production. Here they have good pancreas. As a matter of fact, by the time we go into certain medications that will be useful for the treatment of type 2, we will see that some of them, and majority of them, will actually need a good pancreas, secretor goggles. So they have good pancreas here. Take that. They do. But there's resistance to insulin. Here they will have high C-peptide and high insulin. Why that? The pancreas is working well. Beta cells are working well. Isolate of Langerhans has no problem. Then where's the problem? Yes, they're suffering in the midst of plenty, right? But greater than 75% of people with type 2 will be obese, or BMI will be greater than the normal for their age and height. Okay, the age of presentation here will be variable. Unlike type 1 that I said, childhood mainly, but it can occur in adults if autoimmune surfaces in adult age and it destroys the pancreas. Here in type 2, I'll just leave it as variable in the sense that before the old medical textbooks would say in adult, now type 2 diabetes mellitus could be picked in children. Yes. Once a child is obese, particularly teenagers, they can come down with type 2 diabetes mellitus. Okay, the third example of diabetes mellitus will be borderline or impaired diabetes mellitus. I'll not waste your time. We'll still get more info about that later. Then gestational diabetes mellitus, pregnant women, drug-induced. So you're asking me now that certain medications that some people are taking can tilt them to diabetes mellitus or can worsen it. No, don't worry. We'll get details in a bit. Then maturity onset diabetes of the young. We'll get full info in a bit. Now, the maturity onset diabetes of the young, like we've seen of the young, right? It's going to happen in people less than 25 years. It is non-insulin dependent diabetes mellitus, like type 2. Autosomal dominant will be the pattern of inheritance. So meaning, all you need is one gene from either of the parents. You don't need the two parents to produce, the genes before you can come down with it. No autoantibodies here. So there's no autoimmune condition destroying the pancreas here. And it is just about 5% of all diabetes mellitus cases. The seventh example of diabetes mellitus will be hepatogenous diabetes mellitus. Here, let me first of all ask you, have you heard about that before? Someone will say, no, right? I'm not faulting you. No, that is perfectly okay. Here, we'll go into details, but check my channel through this link. You will find full presentation on hepatogenous diabetes. Right, just click on this very link. It will take you to my channel and you pick the pieces of info on hepatogenous diabetes. But for now, let's continue. Okay, we want to talk more about hepatogenous diabetes, right? So this is the liver. And the reason why I've brought it here is that we should know the organ we're dealing with, okay? So, liver. Now, hepatogenous diabetes. The name implies that the damage to the liver by cirrhosis can lead to diabetes. This is because there is an impaired glucose regulation caused by the loss of liver function. This is curable. Unlike type 2 diabetes mellitus, it is curable. And why that? You know in a bit. Liver cirrhosis and diabetes in hepatogenous diabetes. Is it type 2 diabetes mellitus or is it hepatogenous diabetes mellitus? If you are confused, then we'll answer it here that it is not type 2, it is hepatogenous. And why that? In hepatogenous diabetes, the onset will be after chronic liver disease must have been diagnosed, or at least about the same time that the individual has been diagnosed with chronic liver disease, that the diagnosis of diabetes mellitus will also occur. That is not to say the person couldn't have come down with type 1 because of autoimmune disease somewhere not yet known, or it's not because the person is not having type 2, if there's genetic constitution, obesity, and the rest. That is not what we are saying. But what we are saying here right now today is that it is because there is liver problem here, and that is the cause of this diabetes. Here, you will know more that it is not the other types of diabetes because the risk factors that will point to type 2 diabetes in these patients are not there. Are you getting the point now? Okay, every factors that could lead to type 1 are not found here. And this is not a woman that is pregnant, it's not gestational diabetes. So you have ruled out, you look for, and you couldn't find the risk factors that could lead to diabetes mellitus in this patient. So there is less of those risk factors, but you can handle, you can point to, you can see that there's chronic liver disease already diagnosed, and you know this is hepatogenous diabetes. The clinical features of liver cirrhosis will be present. Okay, you know where we're going now. Less of risk factors for diabetes mellitus, features of liver cirrhosis are present. Then the iron risks of hypoglycemia will be greater than in type 2 diabetes mellitus. So they will have more hypoglycemia. Why that? We'll see in a bit. Then you will be more convinced again that it is hepatogenous diabetes because liver treatment, when you treat the chronic liver disease diagnosed, the treatment will improve the diabetes mellitus. Liver transplantation will cure the hepatogenous diabetes. Type 2 diabetes mellitus is incurable, but hepatogenous diabetes is curable. And how? We cure that with liver transplantation. What are the clinical features of hepatogenous diabetes? Symptoms will start after the onset of liver disease. It may be subclinical symptoms. Likely normal fasting blood sugar will be peaked. But when you do your OGTT, it will be abnormal. The level of hemoglobin A1C will be low. There will be apparent or obvious complications of liver cirrhosis or liver failure. Then there will be less microangiopathic complications or features associated with diabetes mellitus. Still talking about hepatogenous diabetes, there will be increased risk of hepatocellular carcinoma because the problem is in the liver with liver cirrhosis, and one of the complications of liver cirrhosis is hepatocellular carcinoma. Also, hepatic encephalopathy, spontaneous bacterial peritonitis, sepsis, varicella hemorrhage, all these will occur in liver cirrhosis. Renal dysfunction and mortality that is associated with liver cirrhosis is what is going to be associated here. In fact, because of the presence of this diabetes, then there will be increased mortality in liver cirrhosis here. What are the possible causes or pathophysiology of hepatogenous diabetes? There's controversy over that because there's no clear-cut documented pathophysiology of hepatogenous diabetes. And nothing so serious about that. When it is well known by many people, that will definitely come in the nearest future. But there's decreased insulin clearance. And why that? Because of hepatocellular functional loss. And that is the reason why hypoglycemia will be very, very serious here, and it will be profound. Pancreatic beta cells destruction or dysfunction is a possibility. Increased level of advanced glycation end products occurring here, and there is likelihood of insulin resistance due to chronic liver disease. Treatment of hepatogenous diabetes. This is very difficult to treat. Why that? Many of the oral hypoglycemic agents will have hepatotoxicity. Remember, the liver is already in trouble. Now you want to give medication that will add salt to the injury, right? Insulin should be administered with great caution. Why that? They are prone to hypoglycemia already. So oral hypoglycemic agent will lead to more hypoglycemia, but you can try the following. Just know that, so be careful too. That's why I say it's very difficult to treat. Biguanide, metformin, alpha glucosidase inhibitors like acarbose, dipeptidase 4 inhibitors like linagliptin. You can try that. But the best advice is to have a liver transplantation because that will lead to cure, and it's the only cure. In conclusion, these liver-related diabetes mellitus can also be cured by getting a brand new liver, that is liver transplantation. Thanks for listening. Remember to share this. Remember to subscribe to my channel. I appreciate it.